Hello, everyone. Thank you so much for joining us today. My name is Erica Ennis, and I'm with the National Association of County and City Health Officials, also known as NACCHO, and we support the nearly 3,000 local health departments across the United States. So today I'm going to be talking about our continuity of care and breastfeeding support, a blueprint for communities. So before we get started, and for those of you viewing online, if you can just say so in the chat box, but please raise your hand if you've ever had a family member, a patient, a client, a friend tell you they received different chest breastfeeding advice from their healthcare provider than what you provided. Thank you, and please raise your hand if you've ever had to repeat information about your health history, your family history to a healthcare provider. Thank you, and please raise your hand if you've ever had to personally deliver your health records to a healthcare provider instead of them getting it from one of your other providers. So thank you guys so much. And so from the people in the room, it seems like pretty much everybody raised their hand at least once. And so what that is, those are gaps in continuity of care. And so at NACCHO, we developed a continuity of care blueprint because we recognize that most infants in the U.S. start off breastfeeding, but we know those rates decline pretty rapidly, especially in Black and Brown communities. So with funding from the Centers for Disease Control and Prevention, we reconvened the USBC's continuity of care constellation, which included over 1,000 professionals from the field, and we met monthly for about a year and a half, and we discussed different stages of breastfeeding, different gaps in care, and how we can better serve the community. And also because before this, there was no clear guidance for how to promote, protect, and support breastfeeding at the local level. So through our meetings, we came up with 7 recommendations that became our blueprint that we launched last August. So what is continuity of care? So when we're talking about chest breastfeeding support, continuity of care is about consistent, collaborative, and seamless delivery of high-quality services for families from the prenatal period until they're no longer breastfeeding. Continuity of care results in transitions of care that are coordinated and fully supportive of families throughout their chest breastfeeding journey. So our blueprint recommendations. So we have 7 recommendations total, and the first 4 recommendations are really about improving the local community infrastructure. And then our last 3 recommendations are about building the local lactation workforce. So recommendation 1 is breastfeeding as a community health improvement strategy. Recommendation 2 is about breastfeeding policy systems and environmental changes. Recommendation 3 is about transitions of care, accountability, and referral systems. Recommendation 4 is community-driven chest breastfeeding data system. Recommendation 5 is about providing education to public health, allied health, and the healthcare workforce. Recommendation 6 is about ensuring that the lactation workforce is family-centered, there's implicit bias awareness, and that we're using a cultural humility approach. And then recommendation 7, which was led by the United States Breastfeeding Committee, is about creating the local breastfeeding champion role and health advocacy for breastfeeding. So after we launched our continuity of care and breastfeeding support blueprint, we created a funding opportunity for communities to implement at least 2 strategies from our blueprint. So I'm not going to talk about all 10 of the implementations. I'm really going to focus on the ones that are for Black and Brown communities. So Queen City Cocoa Beans, which is a community-driven organization based out of Mecklenburg County in North Carolina, which focuses on supporting families of color, new and expectant families of color. For recommendation 5, they created the Cultivate Provider Training, which is an educational training for providers in the area who serve Black and Brown families. And this training provides nutrition and lactation education, and it also talks about why this work is important because of the inequities that currently exist in healthcare. So for recommendation 6, they created the pilot Daddy Beans Mentoring Program, and this program is for Black fathers in the area to get peer-to-peer lactation and nutrition education, and so Black fathers are better able to support lactation. So So with this mentoring program, they had 13 participants and 4 Black fathers as leaders of this mentoring program. And all of the participants felt like they were much better suited to support breastfeeding, and they also all said they planned to have their children be breastfed. Another really important thing about this pilot program is that all the participants agreed to help promote the program and recruit additional fathers, because we know when it comes to community peer-to-peer support programs, word of mouth is really important. And so our next project awardee was the Black Mothers Breastfeeding Association, and they partnered with Focus Hope, which is an early child care center in Detroit, and they also partnered with the local WIC. So they implemented recommendations 2 and 3, so really trying to build up the infrastructure. So for recommendation 2, they reestablished the Black Mothers Breastfeeding Club at Focus Hope, which is a place where mothers can support and discuss their breastfeeding journey. And they also have a WIC lactation consultant available to assist, and they have community-based doulas who are familiar with breastfeeding initiation available for new and expectant mothers as well. So for years, BIMFA, Focus Hope, and WIC have had an informal referral system. But the issue with informal referral systems is that there's no accountability, and a lot of times mothers fall through the cracks. So what they did was, you can see here, they created a breastfeeding referral flow chart so that everybody understands the points of contact and that there are no mothers falling through the cracks, because there's accountability from all 3 organizations. And another important thing about this referral flow chart is that it provides information to refer mothers who need additional clinical support. And so our next organization, the University of Chicago Medicine, they focused on this project specifically on the Black families in the South Side of Chicago. So they piloted a breastfeeding peer counselor program. And this program, this is not a WIC peer counselor in the hospital. This is their own peer counselor program that they've created. And so for recommendation 6, they really wanted to make sure that they had a peer counselor who was culturally appropriate. So they recruited a Black person from the South Side of Chicago to actually serve as the breastfeeding peer counselor. And also, they partnered with Health Connect One, and they created a web page for Black families on the South Side of Chicago. So they have culturally appropriate resources, but also so they know where they can go for lactation services. And they also created a referral workflow with touch points to understand how many times each family should be seeing a lactation professional. So 2 visits with the breastfeeding peer counselor prenatal, 1 postpartum visit with the breastfeeding peer counselor, and 1 inpatient visit with an IBCLC. And so what's really important about this project is that the University of Chicago is a big health system, and they have lactation consultants available in the hospital, but clearly that wasn't enough, because the breastfeeding rates for Black families in the South Side of Chicago were still very low. So creating this peer counselor program, they're really using this to make sure that they're able to support the Black families in the South Side of Chicago. And so next we have Latina Lactation of Southwest Kansas. And so I'm gonna have Brenda Bandy from the Kansas Breastfeeding Coalition, who served as a partner and fiscal sponsor for Latina Lactation of Southwest Kansas, talk about their implementation.
Thank you so much, and I hope that Carmen Valverde is on the line somewhere with us, because I'm really channeling Carmen's work today. This is, we played a small supporting role in this. I'm Brenda with the Kansas Breastfeeding Coalition, but this is really the work of Carmen Valverde and the Latina Lactation Coalition of Southwest Kansas. And just to get you oriented when I talk about Kansas and what the community work is that she's doing, she is serving the 19 counties of Southwest Kansas, which is a large geographical area. And in those 19 counties of Southwest Kansas that border Colorado and Oklahoma, the population is approximately 45% Latina, because there are 4 maybe 5, meat processing plants in those areas. And they are the largest employers for this area. So that maybe gives you an idea of the landscape of the community in this area that Carmen and her coalition serve. And with this funding from NACCHO and additional funding that Carmen's been able to bring in from Health Connect One, thank you very much, in addition to the United Methodist Health Ministry Fund, she's been able to braid all of this funding together to do the work that I'm going to describe. So first there was a needs assessment where she actually went out to county fairs, she went to restaurants, she went to stores where the Latina families are going, and actually just talked with them and said, you know, what is it like to be a breastfeeding parent in Southwest Kansas? What do you need? What are the gaps? And what she heard is probably not going to surprise you all, but it was that I didn't know where to go. I tried this and I didn't know that there was somebody that I could call. And so that was the overriding comment that she heard. In addition, she also heard I didn't know that I could return to work at these meat processing plants and continue to breastfeed. I mean, that's not something they lead with when they talk about recruiting and working in these places. So those are the 2 things she set out to address. So what you see on the slide is the billboard that she had placed in 2 cities, Dodge City and a second in Garden City, directly across the parking lot from the meat processing plants. So how strategic was that, literally, to say, I can return to work and continue breastfeeding? And that's her phone number on there. They can call for support, and she knows what their rights are, and she knows who inside those plants she can call to advocate on their behalf. She also got a video filmed inside Cargill meat processing plant to show literally where do you go, where's the room that you go to, and how does this work. So we didn't have time to show that video, but that was a part of that. The tent and the tablecloths that you see is her outreach. She goes to the international festivals that they hold in those areas so that she continues to be a presence for families to remind them that she is there. She has a breastfeeding bench placed in the Garden City Zoo. And you think, well, what does a bench have to do with all this? It's the signage. There is a sign there with a QR code that directs families to all of the lactation support in those 19 counties, and which ones are in Spanish. As well. So she has that as well. And then, of course, like I said, the meat press packing plant she worked with very closely. And then finally, another part of this is investment in scholarships. Through the NACCHO funding, we were able to award 4 scholarships. 2 were to community health workers out of one of the regional family health clinics. They're called the Primatoras, and they actually, I just met them for the first time last Friday, and they are older women that have grandchildren, and she sat down and she was like, I thought I was done with this. I had no idea that this was so important to my community, and they were thrilled to be trained as certified breastfeeding specialists. And then we also have a Spanish-speaking midwife that serves the area that is going to be trained to become an IBCLC, and her nurse is also being trained as well, and they serve this whole region. So the scholarships were also critical, that these are the community workers that are serving this population, and we were just able to invest in their education. So that is the story of Latina lactation in Carmen Valverde.
Thank you so much, Brenda, and thank you, Carmen, too, for the amazing work that you've done. So after we launched our blueprint, we also launched a resource repository because we're really big on communities not having to recreate the wheel. There's a lot of great breastfeeding work that's being done on the local level, so instead of people having to reinvent the wheel, we want to highlight that work. So on our resource repository, we have resources for each recommendation. If you're looking for community breastfeeding assessments, you can go under recommendation 1. If you're looking for workplace or breastfeeding friendly policies, you can look under recommendation 2. And we've worked really, really hard to make this website as user-friendly as possible. We also have all of the stories from our past Blueprint grantees, and we're currently have over 60 resources, and we're constantly adding new resources. If you have a resource, you can email us at breastfeeding@nacho.org, or if you're looking for something and you don't find it there, you can email us as well. So I highly recommend checking out the website. And so I'm super excited to announce that for the 1-year anniversary, because we launched the blueprint a year ago yesterday, we are going to be launching another funding opportunity for communities to implement blueprint recommendations. So this funding opportunity is going to be a little different. We're looking to fund roughly 5 community organizations to implement at least 4 of the recommendations, and we are also going to be having an information webinar on September 20th, which you can go to breastfeedingcontinuityofcare.org, and we have information about our next funding opportunity.
Good afternoon. My name is Lillian Scott. I'm a speech-language pathologist and an IBCLC, and this is my colleague, Kristen Cole, who's a pediatric nurse practitioner. Unfortunately, our dietitian, Kelly Brower, is not able to be with us today, but the 3 of us work in a team to help babies and families reach their breastfeeding goals or address pediatric feeding disorders in the outpatient setting. So we're going to highlight some things that our clinic does and a couple case studies. So in this, we are fortunate that some of our patients have shared pictures of their children with us. So we please ask you to refrain from taking pictures of our slides just to protect our patients. We are employed by UNC Health, and I'm going to roll through the objectives because we don't have a lot of time. Do you want to talk a little bit?
So I want to introduce to you what a pediatric feeding disorder is. Has anybody ever heard of that? Oh, good. Some people have. So there was finally a consensus paper written back in 2019. So we have a unified definition of what a pediatric feeding disorder is. But prior to that, there were a lot of different nomenclatures used for pediatric feeding problems. And sometimes people used just malnutrition. Sometimes people used feeding difficulties. Sometimes they were caught by dysphagia. But we really are so excited that now we have a real definition that's unified so that we can advance the world of pediatric feeding and especially research. So really the definition is impaired oral intake that is not age appropriate, and it is associated with 4 different domains, and that is medical, nutritional, feeding skill, and or psychosocial dysfunction, which I always laugh at that because everyone who has a feeding problem has a psychosocial a component, as we all know, and take care of. So we take care of pediatric feeding difficulties in our clinic, and our clinic is set up with 3 different disciplines. We have a medical component, and that's the nurse practitioner component. So we take in a lot of multidisciplinary, really complex patients, and our patients have a lot of cardiorespiratory compromise with feeding. They often are part of our airway center. So these patients have a lot of aspiration difficulties, recurrent aspiration, and we're trying to figure out dysphagia with our very talented speech-language pathologist and how to really manage those complications as well as troublesome GI symptomatology, which can be anything from reflux to visceral hyperalgesia, which I will mention a little bit later. We also have dietitians on our team, and our dietitians are very well-versed in infant and childhood feeding needs as far as nutrition is concerned, multivitamins. We are a big proponent of human milk, and we do everything we can to preserve that, and we're very fortunate that on our team, Lillian is also an IBCLC, so we work really hard to protect breastfeeding and human milk, not only from the wishes of the mother and continuing to promote breastfeeding, but also because we know how important it is for our microbiome. We also have our very talented speech-language pathologists in our clinic, and they're going to be the ones assessing swallow function and giving us guidance on how these babies can eat safely and how we can promote breastfeeding, even direct breastfeeding during swallow studies, so that we can best assess how we can continue that. They also modify positioning, excuse me, and use of different methods to comfort, methods to maybe supplement, and how we can best supplement and preserve the function of breastfeeding as well as bottle feeding if necessary. We also have a psychosocial component, and we are the ones who do that. We do not have a psychologist on our program, so as people have mentioned previously, we all do that. But that's a definite part of these pediatric feeding disorders, and you'll hear that throughout the presentations.
All right, so in protecting breastfeeding and PFDs, a lot of things that we'll talk about in our clinic, and any member of our feeding team will say that when babies feel good in their bodies, they will be able to accept adequate volumes of nutrition to grow, and that they can dictate that volume, that we don't need to be measuring that volume. They'll do it themselves when they feel good. So what can we do to make them feel good? We always ask, and one of our first questions in each appointment is, what is the lactating parent's goal, but also what is your goal for this appointment? Because sometimes we're not there to address the breastfeeding, we're there to address a different component, like maybe their ultimate concern is growth today, or maybe it was like how to get to the appointment, and we need to call in and figure out, make sure we have transportation assessed. In our clinic, we support breastfeeding, chest feeding, exclusive pumping, or when the parents tell us, like, I've had enough, I really need to wean, we 100% support that too. So we're trying to really meet the families where they are, knowing that they're in a stressful place with a child or an infant with a PFD. In our clinic, human milk is not typically the cause of any of these PFDs. In our minds, we can only think of one case in the past 4 years where something was going on in the human milk, and we had to take them off the human milk for about 8 weeks, and that mom chose to exclusively pump, and then we got him back on human milk and back to direct breastfeeding. So we were not trying to sabotage the human milk at all. We just had to get that baby comfortable and growing, and then went right back to breastfeeding. So that's only one time. Our clinic is set up, we run in teams. So Kristen, myself, and our dietitian Kelly, all three of us are in the room with the patient at the same time, collecting history, getting information, getting all that information, and assessing feeding in that same time. We also have another clinic that is myself and another RN IBCLC, because I'm totally a baby IBCLC, and when there's maternal things going on, I need someone else to help me out, and 2 heads are better than 1. So she and I run a clinic on Mondays, and oftentimes our babies kind of go systematically back and forth between the 2 clinics so that we can address all of the lactation needs and meet the goals of comfort too. Just briefly, some barriers and positives that we see in achieving exclusive breastfeeding in the outpatient setting, especially with our premature babies. Barriers are kind of how the NICUs in our community are set up, with recommending fortification, volume goals, told they need to breastfeed for 30 minutes for it to be successful, sent to home bottle feeding, and then having the parents have these fears of growth. Some positives that we see once we get to the outpatient and the benefits of our clinic is we can adjust to home life, where we feed a little bit more on feeding cues. We're really there to support the gut comfort and can really kind of have a lot more leeway to achieve these goals. Our dietitians are phenomenal in looking at more than just weight on a growth chart. So we are taking, I joke that our dietitian is like Ollivander trying to fit a wand in assessments, taking all these measurements. And so they're doing weight, length, weight for length comparison, arm circumference, but then the biggest key that they really do is they take a visual assessment. We're always talking about how many rolls that kid has on their thighs, and they look good. And if you're only so long, you can only weigh but so much. And so what are we doing? Are they looking healthy and proportional versus truly malnutritious? And we need to do something else. And then our dietitians are always thinking too, like, well, what can we do to improve the comfort so they want to eat a little bit more? So now we're going to jump into some case studies, and this first one was born at 30 weeks gestational age, spent about 10 weeks in the NICU, discharged from the NICU on human milk fortified with pure amino to 24 calories per ounce, and would take about 15 to 70 mLs through the Dr. Brown's transition nipple. This was first-time parents, mom identified as a mother, and she was told that she could not breastfeed exclusively until the baby would latch for 30 minutes. This baby would only latch for 5 minutes on one breast. And mom had massive oversupply. She was easily pumping 28 to 33 ounces a day with 4 pumps. That baby would only feed for 5 minutes. And she's sitting there like, I just can't breastfeed. We're just going to have to exclusively pump the first time I met her. I was like, have you done a pre and post weight? And she's like, no. And I was like, okay, just hold on. Let's do this. And I was like, that kid's drinking a lot. So in that assessment, sure enough, the baby took 52 mLs in less than 10 minutes, was comfortable and felt good, and her body was showing some signs of reflux. So we And I also did an oral MEC assessment, which is a whole can of worms. This kid did have a Kotlow for lingual frenulum with a heart-shaped tongue, but however, just breastfed beautifully. Mom was not having any pains or concerns, so that was not a priority. We can have a whole nother conversation for 5 days on tongues. So after getting all the information, recommended removing that fortification because her growth curve looked fine, and addressing the mom's milk supply so that the baby was not feeling overwhelmed at the breast. And then mom was already dairy-free, and we went ahead and got him in the same day, or next day, to our feeding team, just to have GI and dietitian lay eyes on her and say, like, yeah, all human milk, let's go for it. And that's what they did. And additionally, the GI nurse practitioner adjusted the famotidine reflux dose just to be more appropriate for the weight and therapeutic. So this baby transferred really quickly to exclusive breastfeeding, not even breast milk in bottles. We went really quickly to exclusive breastfeeding. By 4 months of age, a little bit sooner, we were there. And then we went and did the lingual frenotomy just to make things effective, because as mom's milk supply was coming down, then it might have been a little bit more difficult to transfer. And we felt as a team and in discussion with mom that that would be of benefit. So we had one of our pediatric dentist colleagues do that and do the assessment, and they have a clinic with an IBCLC and a body worker, so all top notch. So then we meet our friend who is exclusively direct breastfeeding and cute as can be. And so during this time, mom is a first grade school teacher. She is fantastic. She did pumping until summer, and then by the time they got to summer, we were like pumping at work and then at full breastfeeding. So this is kind of the timeline of their event. So exclusive breastfeeding throughout the summer. We did that frenotomy. Mom returned to work in the fall, so then we had to do some pumping while at work, and mom had downregulated her supply. Her goal was to offer exclusive human milk until 1, and then that became 1 corrected age. And then that carried on. And so once she hit the 1 corrected age, we were still in the school year, and she's like, I can't pump at school anymore. So we went ahead and did a little bit of a Cape Farm instead of going to cow's milk, because just looking at this child, she's petite all around, but we just wanted to do that instead of doing cow's milk, wait till summer, and that just had a little bit more nutrition for her dietitian. Then in the summer, she returned to exclusive human milk, and we did start introducing cow's milk. The funny thing in this appointment is she was like, so I need to transition her to her room, right, and stop like night breastfeeding. And I was like, and dad's also hilarious and fantastic. And I was like, well, you know, the biological norms, if this is working for you, keep on going, and provided some education. I was like, you're meeting these goals and exceeding these goals you've set for yourself, so you might need to find some other over 1 breastfeeding families to be in your corner and support you in night feeding. And dad looks over and goes, she only feeds for 2 minutes and you don't even wake up. I was like, okay, so it's not a problem. So here is the cutie. And then quickly, I want to share the growth chart just so you have an idea, because if we put her on the World Health Organization growth chart, she is preemie. This one's not corrected for her corrected age, but she's not at the 50th percentile, right? She is making proportional gains and moving up and doing catch-up growth, and our dietitians really acknowledge that. And in this picture, in weight for length, you can see the rolls on her thighs. So we know that she is just growing per her, and we're watching really closely and maximizing nutrition there. All right.
Okay, so in our clinic, we do a lot of tube feeding, and that is necessary sometimes. And this is kind of an outline of why it would be necessary. And like I mentioned, we have a lot of babies in our clinic who are very complex medically, and a lot of them come from the NICU. So these babies are not only premature, but they might have heart disease, lung disease, really significant swallowing difficulties, and sometimes it's necessary for us to take care of them out of the NICU with a tube. But we always want to assess, and we do in our clinic, whether or not we can wean these patients, and really the idea is to wean them as quickly as possible from the bottle or from the tube feeding to the bottle to the breast, if that is the mother's preference. So we work really hard to do that, even despite all of these medical challenges. The keys to weaning successfully, and part of my job, the biggest part of my job, is to make sure the babies are comfortable. So we look at how much they're stooling, we assess for reflux, we really take into account their early pain experiences. These babies have a lot of interventions from birth, and we know that those are learned experiences in their neurological and GI tracts, and they have inappropriate pain responses sometimes that we really have to adjust for and we really have to treat. We want to make sure that they're not having vomiting, gagging, or retching, because let's be honest and just think about it very linearly, like who wants to eat after they vomited or retched? Nobody. So in pain management, I already kind of alluded to that, and that has to do with that hypersensitivity response. We also look a lot at their motor development, and Lillian is so great at this with looking at tummy time. She and I work together to move the baby, see how they sit up when we're progressing to oral feeding skills like eating by spoon. We want to make sure that they've progressed past tummy time, they're sitting. We're looking at the baby as a whole. Positive experiences with feeding. We look at cultural norms, supported positioning, and also caregiver competency with whether or not they can take care of the NG, the G-tube, or whatever else it is that the baby comes out of the hospital with. And we take that into account in how long those external helpful devices are used. And then hunger. We have to allow our babies to be hungry, and we can't feed them 100% of their nutrition via the NG tube, which is really hard for us sometimes with our dietitians. We can't provide 100% of a baby's needs and expect that they're going to want to breastfeed. They're not hungry. So we have to really take all of those things into account. Whoops, I went backwards. So there are two studies, and I'm just going to briefly mention these. This first one was done at Nationwide Children's Hospital, and basically they looked at babies who were less than 34 weeks of gestational age who started oral feeding in the NICU, and they were trying to look and see if they had more oral acceptance prior to removal of the G-tube, if they would eventually come off of that NG tube sooner. What they found out is that it was actually a trend that the group of infants that was 50 in the 60 to 79% oral feeders, they actually went to goal volumes quicker than the babies did that were at 80 or 100% of intake orally before the NG tube was removed. So what it kind of challenges us to do is think about when we can remove these NG tubes, and babies don't have to be taking 100% of their oral intake. They don't have to be taking 75% of their oral intake. And it's specific to each baby, but these kinds of studies we are trying to do more of so that we can really help educate the NICU providers as well. So maybe these babies can come out of the NICU without the NGs as well. The study was actually done at Duke, which is just down the street from UNC Chapel Hill, where we practice. This was done in their level 4 neonatal intensive care unit. This study looked at hospital days and how we could prevent babies from going on to G-tubes or staying into the hospital longer by going ahead and discharging them with NG tubes. So basically what this study found out was that the babies used an NG for only about 12 days. That was the median. There were a few outliers. But by using the NG tube instead of keeping them in the hospital or moving to G-tube and discharging them with that NG, they saved about 8 days per patient in the hospital. When you're thinking about healthcare dollars, that's tremendous. And we're seeing these babies in our outpatient setting, so we're really trying to promote, yes, discharge them before they have the NG tube out, but also discharge them when they still have it in, and we will work on oral feeding. So my role, as I mentioned, really is to take care of the medical needs of the patient. I often really try to manage expectations from the beginning. As Lillian mentioned, we really do partner with our families and say, we want to know what your goals are. We want to know what you feel like you're capable of doing, your support systems. How can we really partner with you now so that we can reach the goals long term. Some patients come in and tell us we cannot foresee having this NG tube at home. We just can't do it. And we have to meet them where they are. I will let you describe your role.
Since many of y'all are in the field of lactation, I'm sure you're familiar with the role of IBCLC, but obviously we're there protecting the human milk, providing bonding experiences, especially if they're getting all their nutrition through a feeding tube, and then really supporting the dyad to work together on the parents' breastfeeding and chest feeding goals in the context of weaning this tube and with the rest of the team. So sometimes it's a lot of skin to skin or non-nutritive sucking at the breast, which is great in the beginning. And then in speech language pathology, we're looking at the skill set of the infant to accept nutrition and swallow safely. So that's suck, swallow, breathe coordination, and then also kind of talking with our team to help facilitate the plan, while our dietitian is taking her measurements, doing her assessments, and kind of guiding on how far we can push to cut tube feeding, to cut some of the tube feeds and encourage and provoke hunger and kind of lead it from a nutrition standpoint. We do know when we make changes, we do expect bobbles and weights. So we have a few minutes to go through one of our case studies, and this one was born at 26 weeks gestational age, twin gestation, the twin with PROM, or PPROM, and spent 4 months in the NICU. The last 3 to 4 weeks were exclusively to work on oral feeding and wean that tube, and was met with no success in vomiting. So then finally, at Mother's advocacy, as strong advocacy as well, the team decided that they would discharge her with an NG tube. The NG tube, she was receiving human milk fortified with NeoSure to 24 calories an ounce, accepting very minimal amounts by mouth, refusing bottles flat out, doing some breastfeeding, but not significant transfer. And so they went ahead and did a swallow study, a modified barium swallow study, or video fluoroscopic swallow study to assess, to make sure everything was going down the right way and there was no pharyngeal problem. She was functional. She accepted thin liquids through a Dr. Brown's preemie nipple with no concerns. Mom had extensive breastfeeding experience. She had 5 older children that all breastfed for at least 18 months. 2 of the 5 children had had acneloglossia or tongue tie. And so that was something that she was already tuned into and asking questions about. Upon discharge, they got quickly into our clinic and saw our feeding team, who diagnosed and assessed visceral hyperalgesia, which is looks into polyvagal theory and that pain response system, that if you've been exposed to a lot of painful things in your life, then you kind of hit a fight or flight, and your body just can't tolerate. So that nerve, the vagus nerve, goes down along the GI tract too and just leads to vomiting and feeling uncomfortable. So of course you're not going to want to eat. So Kristen prescribed gabapentin, which is a pharmaceutical that we can use to treat that and kind of realign the neurons of the body. And then the dietitian switched her to human milk, actually switched an extensively partially hydrolyzed formula first with the breast milk to fortify, and then eventually went to direct human milk. But any direct breastfeeding did not obviously need to be fortified, and we were encouraging that because we knew that she was not going to take a bottle and it was not in mom's interest. So as the IBCLC, we encouraged feeding on feeding cues, breastfeeding, and using the breast for comfort, and because it was not mom's goal, we were not going to offer a bottle. As the SLP, I provided education with mom that she wasn't having any pain or difficulty with the latch for breastfeeding, that let's wait and see on that tongue tie and see how far we can get once we get the visceral hyperalgesia under control. So the outcome is that our friend weaned from the tube in 34 days with this medication and the adjustments made. She breastfeeds frequently, every 1.5 to 2 hours, which is fine by mom. No bottles were offered, and weight gain was standard for age, but not for catch-up. There was no gagging and vomiting. That completely resolved. After we achieved this feat, we did talk a little bit later and end up doing a lingual phenotomy, but we weaned the gabapentin first. And so here's a peek at her growth chart across time. And then I don't know if you want to take a minute or two to talk more about the gabapentin. I think we only have that and then questions.
Yeah. So I'll talk just shortly about the gabapentin. So we use this neuromodulator. It's really a chronic pain medication. It's been around for a really long time. I really feel comfortable using it. It has very minimal side effects. And we use it in a lot of these ex-preemie babies who they're really overly sensitive to things that they shouldn't really feel. So what I say to my patients is, it's kind of like you have an alarm system in your house, and the alarm system starts to go off every time the hair from the dog on the comforter moves. So it's going off all the time. These bodies of these little babies are going off all the time. They see food, they turn their head, they start to digest, they start to have peristalsis, and it has a response in their bodies. It's hypersensitive. They gag, they retch, they vomit. But what we want is we want that alarm system to only go off when there's a burglar coming in the front door. We want that alarm system only to go off when we have a GI bug, and we really need to get that stuff out of our stomach. We don't need that happening all the time because that's going to prohibit progressing with oral feeding. So we do use this a lot in our practice. I'm very, very happy to talk to anybody about it afterwards. And we see probably more success with this medication than any of the other ones that we use. So we had one more case study, but we don't have time to share it. But thank you so much for listening. Thank you so much for allowing us to be here. We are both so enthusiastic about our ability to help on the inpatient and outpatient side to help with promoting breastfeeding and breast milk with these premature babies.